Voilà.
Good evening, ladies and gentlemen. Good evening, mostly ladies and some gentlemen as well. Warm welcome to all of you in the name of the Council of Aldermen of the Municipality of Luxembourg here at the Tram Shop for a conference. It has lasted quite a while, but it should have taken place 2 years ago. But at the end of the day, finally, we can talk about this topic being a really important topic. At that. Before we get started, did you get a headset for those needing interpretation?
The translation, please go outside. There are some headphones to take some translation. Voilà.
Here we go. I'm really happy to be able to welcome you as a member of the Council of Aldermen, Claudia Ireland, member, chairwoman of the Equal Opportunity Committee as well, and it's my topic as well as Alderman. When I became member of the municipality in Luxembourg, I learned, amongst the things, what endometriosis was. It took me a while to learn the word as such and to pronounce it correctly. But I have to say it was a major opportunity as well. In my family and friends surrounding, there's no one concerned by this. And so if you don't know people concerned yourself, it's not a non-topic. And that might be one of our tasks, thanks to the conference tonight, the workshop that took place a month ago, and the other municipalities. There's a whole series of associations got involved as well, and we are trying to remove the taboo aspect about this topic. It concerns 1 in 7 women. Those women being concerned, or the girls as well being concerned, are really reducing opportunities on a daily basis. So it's really a problem a day. Not, I'm talking to you like an expert, but that's what I was told, of course. But it's really a daily matter, and it is of the utmost importance here to make sure that we get rid of the taboo around the topic. And I think it's the first conference we organized about this topic, and I have to say I've rarely seen so many feedbacks from people telling me, oh, great, finally we'll have the opportunity to talk about. Most conferences are about topics that have been known for a while, but this one here is really new. You could really feel a lot of people concerned saying, oh, it's great, finally I can talk about it with other people having the same problem, and really find an opportunity to have an exchange with other people. And this is of the utmost importance, as I said. It's a chronic disease directly linked to the period, and it is really in the middle of life, of daily life, and daily life is reduced to such an, and that's why it's important to organize this as a city of Luxembourg with Didelange and Bettenburg to organize it together, involving all associations working in this area as well. This is an element of getting rid of the taboo, as I said, around the whole topic and discussion of the period and of menstruation. And, well, obviously we still need some time, but proactively we have to take up the fight, talk about it in order to make sure that this topic gets out of the taboo corner. And that's why I'm really happy. And Chargé d'égalité, Anne Maki, responsible for equal opportunities, has delivered a lot of support, and she had great input here as well, trying to implement this as quickly as possible. Last year, we decided, as City of Luxembourg, after Walferdange had given the example, we've decided to have hygiene boxes installed in public lavatories, and there was a pilot project in a primary school as well. And this project will be evaluated as well, and we will probably extend the project as well, because this is part of this whole discussion as well concerning the menstruation period. And I think this is another possibility to contribute to a situation where we offer a higher level of comfort to all persons. And as politicians, we have to get involved as well. This topic is in the public arena, and we have to deliver answers to all those questions, and we will be evaluated based on these measures, what we have done to make life easier for so many people. And that's why I'm really happy tonight that we've been able to organize this event together with all our partners being the municipalities of Didelange and Bettenburg. Didelange, the Equal Opportunity Service team, and Bettenburg also the Service for Equal Opportunity being involved here. And I'd like to welcome them here. And the Tramshop and the City of Luxembourg associations, we have Citfrauen and Gender, CESAS, National Reference Center for the Promotion of Affective and Sexual Health, CESAS. I think right now they're in a very active role. I'm really happy that they have found time to be with us tonight about affective and sexual health. They had a major event this week as well. Congratulations for that as well. This is one of the topics that has to put on the public stage as well. We have to talk about it, absolutely. Then we have the Center for LGBTQ, TIQ+, SIGAL, involved here as well, an association I pay a lot of respect to for the very valuable work they're delivering. A month ago, as the City of Luxembourg, they've given them the Prix Beffert, an award for equal opportunities in the City of Luxembourg, and we are really happy to continue this cooperation tonight as well. And last but not least, ALAF, the Luxembourg Association for the Friends of the Louvain Foundation. I think it's really good that we have a partner from the academic area as well, allowing us to put together an interesting and great panel. And that's why I would like to say thank you as well to Professor Squifflet from the University of Louvain to be with us tonight. It's really a great pleasure to have you with us, because it is important to have a look at this topic from all its facets. And your presence here in this event is a great honor as well. And I'd like to introduce you to participants of our roundtable as well, a panel discussion, being part of the workshop that was organized 4 weeks ago here in the city of Luxembourg. And that's why I'm really happy that we have a whole series of experts with us for our panel discussion, starting with Professor Jean-Luc Squifflet, gynecologist at the Saint-Luc University Clinic in Louvain, Belgium. Welcome. Please allow me to welcome Susanna Hilton, orthopedic therapist from Germany. Warm welcome to you as well, honoring us with her presence here tonight for our roundtable discussion. Then Anne-Marie Antoine, family planning psychologist, and Dr. Max Stieber, gynecologist at the Bohler Clinic in Luxembourg as well. Thank you very much to all of you for your availability concerning this topic, where it is of the utmost important in our view to put a focus on it and to talk about it. It's only by talking about it that we can see an improvement in the information work for the general population and helping persons concerned. All this will be moderated by Anne Schaaf, journalist and moderator of the evening discussion. So I've talked enough as a politician. I'd like to give the floor to Annabelle Lavarieux-Safran, the responsible person of the city of Nederlangen for equal opportunities, and then we'll get started with the debate. But please, I'd like to thank all the associations having prepared a booth just in the entrance hall. You can get more information. You can have an exchange there. It's a great moment for that, but I'm quite convinced that this might be the first conference on the topic, but certainly not the last that we will have to about this. So one last remark, please. Excuse me. Tonight, one of these days when lots of different events are taking place at the same time, and as a Council of Aldermen of the City of Luxembourg, we are paying visits to our citizens as well. And that's why we have a meeting at the Bonnevoie at 7 o'clock, Council of Aldermen on tour, and fortunately I started with a speech at Bonnevoie. Then the mayor allowed me to come here for this introductory speech, and then I will have to leave you very soon to answer possible questions at Bonnevoie as well. Thank you very much for being with us, and I wish you best opportunities for an exchange of information. Thank you very much, and have a pleasant evening. So, thank you, Mr. Bauer. Dear all, I'm very pleased that we are meeting here tonight on this subject. This conference is an absolute matter of the heart for some of the organizers here. Considers people who are affected by endometriosis or who deal with it professionally or for other interests know that it is a complex disease. There's a whole panoply of symptoms of suffering and improvement possibilities that vary from case to case. This disease has a physical and psychological effect and can, especially due to the diversity of each case, remain undetected or unrecognized for a long time. This is why endometriosis is called the chameleon of gynecology. Today we have brought together experts from different fields because the multifaceted effects of endometriosis from different sizes must or should be treated and accompanied in different ways. This event is attended by various services and associations in the field of gender equality. Endometriosis is known as women's disease. In our work, it is a subject that women cannot always and everywhere freely decide about their body, that their body is again and again seen as an object and not as a living person. that their complaints are often less well heard, and that their needs often become more neglected. Some women suffer from the fact that menstruation, sexuality, and especially non-male sexuality, as well as fertility, are still socially taboo. And we know that if this is the case for women as compared to men in our society, then people who do not find themselves or recognized in these traditional gender categories will find it even more difficult. These are, for example, non-binary or trans people who may also have endometriosis. And all of these difficulties are reflected in various life stories of people with endometriosis. The fact that endometriosis is considered as a female disease and is related to these inequalities makes it an issue in gender equality as well. We've come together and met as people who are concerned and who know those involved to organize this information evening. Experience has shown that many people concerned often know more about endometriosis themselves than some of the professional helpers they turn to. And they themselves are the experts of their personal experiences and their own lived examples. And that's why we held 2 workshops for those concerned in the run-up to this event. At first evening, over 20 persons concerned testified, and these testimonies were involved in the preparation of the roundtable. In the second workshop, we gathered information, ideas, and needs based on our experience. We have exhibited the results of the evening outdoors here, just in the entrance hall, and we will bring them to you as a reflection. We look forward to seeing more medical professions here today who can complement the collection of one of the posters to further their professional needs as well. We would like to thank all people involved in the workshops for their courage and also their mutual support that we could witness there. And you, dear people, thank you for coming to inform you about endometriosis. From today onwards, we will share with you all the social responsibility that all persons with endometriosis can be accompanied as well as possible. I'd like to give the floor to Dr. Skifle now, who will talk to us about the current advances in scientific research into endometriosis and explain what is the present state of the matter. Thank you very much.
Merci pour l'accueil.
Thank you very much for your warm welcome. It is always a pleasure to be able to exchange on this complex pathology. I was talking to people, and I have said many colleagues that I know come to Brussels, so it is obvious that I should come to Luxembourg once in a while to do them the same favor. Let me specify something. I don't know who can actually say they're an expert. The thing is, we have experience, our patients have experience, and it is important that they should be able to express themselves about it. However, please let me tell you that we learn a great deal, not only from our own experiences, but from the experiences of our patients. We must remain humble in the face of this extremely complex pathology. So what is endometriosis? I also will be telling you about our medical knowledge and the limitations thereof. I will then go into the multidisciplinary approach when we deal with our patients. It is fundamental that I, for example, as a gynecologist, should be able to access other medical experts to deal with my patients. And then I will finally give you some good news about medical research and the status quo, because there have been some advances that have been made. So endometriosis is defined by the presence of an endometrium that is a lining inside the uterus, and normally this is regenerated every single month. However, the endometrium can place itself outside the uterus, and that is why we call it the illness endometriosis. So that is one of the potential explanations as to the origins of endometriosis. Some people, however, are born without uteruses, and they can also suffer from it, and there have been some cases of men that suffer from endometriosis. So we don't know everything that we need to know. Now, as to the location of the endometriosis, it can be located near the ovaries, in the area where the ovocytes are located and which guarantee female fertility, and there can be cysts of blood which are dark coloured, and that is why we call them chocolate cysts as well. The white dots are the ones on the ovaries, and there can also be small dots of white, black or pink endometriosis which can be located on the peritoneum. Now, the structures can move, so please be aware that ovaries move. But unfortunately, with endometriosis, the ovaries lose their mobility, and this has an impact on fertility. The third most infrequent location where endometriosis can be located is a so-called deep endometriosis. So we can see the summit of the lesion between the uterus and the large intestine. And this can often cause very serious problems on the woman's health, and it can have a severe impact on the sufferer's life. Now, the most common theory that is applied to explain the origin of endometriosis dates from 1920 by Sampson. The theory is that the lining is ejected from the body during the periods. However, some of the lining remains, and it is possible that some of the debris from the endometer will stay there and will lead to the perinatal lesions. So the reflux of this lining occurs in approximately 90% of women. However, people who suffer from endometriosis only represent 5 to 10% of the population. Now, as a medical practitioner, it is important to talk to patients because it is a complex matter, and we need to establish a connection between the pains experienced and the pathology. There are sometimes lesions that are only seen at the gynecological examination, and this can be quite painful. There are, of course, very highly specific tests that can be carried out, such as MRIs or echographies. And it is important also to be able to provide some treatments, and these can include hormonal treatment, painkillers, or even surgery. So, what is the likelihood of finding endometriosis? This examination was carried out on adolescents, and it is clear that there are 5 to 7% to 10%, of women that suffer from endometriosis. However, they do not always suffer from pain. Sometimes if women suffer from pain for over 6 months, we can see that 25 to 38% of these women are suffering from endometriosis. In such cases, we will provide hormonal treatment, painkillers, to help them handle the pain. If this does not work, then we perform further tests, and if the women complain that the pain is not being resolved through the other treatments, we can see that the problem will probably still be there. In 50% of the cases, in the cases of infertility, these are often due to endometriosis. It does not necessarily mean, however, that that endometriosis is the root cause for the pain or for the infertility itself. That remains to be proven. Now, here we have some images. There is a cyst in the ovary, and as you can see, it looks dark brown, so like a chocolate brown color, and it will be removed. Now here with the arrow, the white arrows, you can see that the ovaries are able to move, and there are some small white dots, and this is endometriosis, but these lesions can only be seen once a paroscopy has been done. Laparoscopy, sorry. And there are also some darker or thicker forms of lesions or deeper forms of lesions, and also adhesions where we can see that the certain elements are stuck to each other, such as the ovaries, which means that this can lead to infertility. Now, what can we say about the reliability of the information that we have? How can we explain the various links between the symptoms and the pathology to our patients? Well, there are different levels. First of all, we look at the level 4. First of all, we can have experts that meet and they might have a coffee together, and they will decide or they will discuss what can be done in terms of cysts, for example. So such opinions being exchanged are not based on studies themselves, but on simple discussion. Now we have, for example, the level 3C. Here, observations are carried out and links can be established. So, for example, if you go to a lake and you see 5 ducks, one of them is white, everybody knows that you don't have 20% of ducks that are white. But if that is the only observation you can make, you can maybe reach that conclusion, despite the fact it's wrong. So those are case studies. Now, on the level number 2B, you have a cohort study, and this will be compared to another group, a randomized group. So we have 2 different groups, population groups, and one will be given treatment, the other one won't, and then the results will be compared. If I only study my patients, well, my patients virtually all complain about endometriosis, and so I will, my observations will be different to a colleague of mine's who deals with other types of patients. Now, in terms of reliability, the most reliable type of study is a randomized study. Here, in such cases, we take a large group of patients, and in a completely random fashion, we give them a treatment that isn't. And this group is compared to another group who is given a placebo treatment. And the patients and the doctors do not know who has access to which treatment. That is the most reliable form of study. Now, when we discuss fertility, we have studied couples who had an infertility problem for over a year. and we have detected endometriosis in these patients. So the women accepted to be part of a study. One group was operated. They received laparoscopic surgery. And then underneath, we have a second group where the presence of endometriosis was proven, but no surgery was performed. And here, as far as the study is concerned, we studied the women for 36 weeks, and we saw the following. There was 17% of the women who were the object of a surgery who, the ones who did not receive surgery, 17% of them fell pregnant within 3 months. But 30% of those who underwent surgery fell pregnant within 3 months. The problem is there is no explanation for the remaining 70% who were operated on but did not fall pregnant. Now, there is a problem on the level of pain and the evaluation of pain. So studying and carrying out randomized studies by selecting the patients and treating them in a random fashion are most certainly the best form of studies to study the efficiency and efficacy of treatments. Let us have a look at these two tables. There is a new treatment which is quite recent, and some tablets are given to women to induce menopause. Now, in the case of a menopause, there are no hormones in the body anymore. So you would expect endometriosis to completely disappear. So here we have carried out a study in which the green group does not receives a placebo effect. The purple group receives a minimal treatment to induce menopause, and the blue group receives a larger dosage of the treatment. 75% of the patients that receive the full-scale menopause treatment see their pain reduced. And what kind of pain am I talking about here? Well, it's the pain that women experience during their periods. So unfortunately, however, 25% of the women who underwent the full-scale menopause treatment still suffer from pain. But it must be said that at least 50% are not suffering from the same pains anymore. So there are pains that are experienced during periods, and some women experience pain outside the time of their periods. So this is a very telling in terms of the variety of symptoms. So the fact is, one type of treatment may not be sufficient to treat all patients. Now here I have a picture depicting how to treat pain related to endometriosis, and some various types of painkillers were given. Sometimes menopause is induced by means of hormone treatments. We have NSAIDs that are provided, or surgery. Of course, if endometriosis is present on the level of the intestine, the likelihood of having intestinal symptoms is higher. However, if it is on the level of the bladder, then the symptoms will be more on the level of the bladder. However, the pain is not very revealing. It is possible to have a cyst on the right of one's body, and yet the pain is felt on the left. So you can have a stage 1 or stage 4 endometriosis level, and it has different impacts on infertility. So some patients come with huge cysts and don't even know why we even want to operate them because they can't feel any pain. On the other hand, the opposite has also been seen. So we talk a lot about the various medical treatments that can be provided to help resolve the problem of pain due to endometriosis. But there are also other ways, for example, to handle pain. There is a psychological, sexological care that can be taken. The patients can often suffer greatly due to the non-effectiveness of certain surgical interventions. A lot of patients find that they feel anxious, stressed, depressed, guilty, especially during their periods. And the problem is that there is a lack of recognition for the pathology, and sometimes no care is taken properly. We carried out a study with patients that had undergone surgery, and they also benefited from physiotherapy, from psychological support, and so on. And this multidisciplinary approach led to the following results, i.e. some patients would receive some food supplements. Sometimes they would have true physiotherapy to handle the pain. They would have neurological care. And so there is this multiple approach to dealing with these problems. And you can see from these two groups that the patients that benefited from a multidisciplinary approach to their pains had a much more successful experience with the management of their pain after a year. So it is very important that multidisciplinary teams take care of women with endometriosis. Now let me give you a message of hope. There have been phases in the past where people spoke about endometriosis a lot, and other phases where it was spoken about less. Well, it is important that you, the patients, give society information, that you be involved in the research, and that will help the efficacy and the efficiency of the care received. The French, of course, love to talk, and the French like to, bitch about things too. So, the French tried to adopt a series of recommendations. They decided that it would be necessary to have better communication, a national register on endometriosis, a center for research, and so on. But the thing is, there is no Belgian, for example, endometriosis register. We don't know if there are 2% or 40% of people who could be on that register. The aim was also to create an observatory and a reference center to allow patients to go and receive information and care for their endometriosis. I think that the care has to be adapted to the patients themselves, because their symptoms do vary. I tell my patients, for example, I'm not interested in whether you have endometriosis or not. What I am interested in, however, is how it was detected. Do you have an infertility problem? Do you suffer from pain? Was it just simply detected through other tests? It is fundamental that these patients be able to manage their pain, that they be able to reduce their pain, that they be able to become fertile, and so on. So there are many recommendations in place. And it is fundamental that the experts communicate with each other, with the patients, that they promote the dissemination of information. And yes, indeed, there is a great deal that we still need to do. Of course, there are some important things that we need to do. We need to carry out some studies. We need to publish our results. We need to discuss the complications that we're dealing with. And we also need to promote research. When you go to reference centers and to expert centers, it is important. If you are asked to participate in studies, it is because the medical profession wants to make progress on this matter. And of course you can choose whether you participate in such studies or not. But it does mean that the experts trust you, they trust your knowledge. And by testing techniques and drugs, it is truly important. Please be aware that the pharmaceutical companies are not behind us funding all this. So if we ask patients to participate in studies on endometriosis, it is so that we can move forward, make progress, and propose better treatments in the future. So I do encourage you to participate in such studies. Now, you might have heard of diagnostic tests without surgery. So, as you know, we all have DNA, and there is RNA. So, as you know, in order to know somebody well, we have to analyze everything they do. We know what they produce in terms of waste and so on. So microRNAs are a form of debris in our blood, in our body, that reflect the waste from our DNA. It is found in our saliva as well. And when this microRNA is analyzed, we can see some abnormally high or low microRNAs. And these are analyzed in terms of specific criteria. And these can be analyzed in various patients. So we can analyze them in patients who suffer from endometriosis and others who do not. How is this done? A little bit of saliva is spat into a tube, and then it is sent to a lab where it is analyzed. This allows the lab to determine whether there is a potential presence of endometriosis or not. And this is a French study. Here we have, in this French study, 75% of people who suffered from endometriosis, and the 96% of the people suffering from endometriosis had a positive test in that test. There was also another group that was tested who had undergone MRI scans to determine whether they had endometriosis or not. The advantage of microRNAs is that it is a non-invasive technique to determine whether there is endometriosis or not. This is something which is not on the market yet. It has been. It is undergoing testing at the moment, and we have hopes for the future. So what have we learned here? We have learned that we can ask ourselves questions and make studies. It is patients, you, the public, associations that are going to improve the quality of the experts centre. As you can see here, you have a centre for a ranking centre that is established by Le Point in France, and they use various criteria, and they analyze the situation in various expert centres for surgery. So the criteria analysed is, for example, how long do the patients stay? How many surgeries are performed? What is the pain management like? Are there sexologists involved, psychologists involved, dietitians, and so on? Are there multidisciplinary meetings that take place? Is everybody able to provide their opinion? And how is infertility and fertility studied? Because as you know, endometriosis has an impact on infertility. And so a treatment of endometriosis can have an impact on a young woman's future fertility. So the eggs may be frozen and so on. We do know that such procedures are not necessarily reimbursed, but in future, this may be the case for the eggs frozen for patients suffering from endometriosis, and I do think that it is important for the future recognition of this pathology. Thank you very much for your attention.
Alors, un grand merci à Monsieur.
Thank you very much. Dr. Kessler, let's start a roundtable discussion now. So, I'm sorry. Before we'll get started, I'd like to repeat once again the names of our guests. So you just listened to Professor Skifle at the Saint-Luc University Clinic, then Mrs. Susanna Helte, naturopath at Merzig in Germany, Mr. Dr. Stiber, oncologist at the Bola Clinic in Luxembourg, and Mrs. Anne-Marie Antoine, psychologist at family planning familial. Before we enter into the subject, I'd like to give you a few initial remarks concerning our procedure tonight, the questions and answer rounds. Mrs. Labrie-Safran has explained already how the conference was prepared. There was a conference with about 30 people, and I collected some quotes that have structured my questions that I'll ask to our panel experts tonight. The first quote here was quite well known. So maybe one question for our public to start with, and then the real round of questions for our experts. Who has heard about endometriosis before this conference? Who has heard about it? Oh, that's good. Quite impressive indeed. Thank you for that. Because I've chosen to choose one quote, which is quite often an answer when a person is concerned talking about the diagnostic result. When they say I have endometriosis, people told me that quite often the answer was, and the water, and the vat in Letzebusch. Oh, is there a problem? Could the interpreters give us a test? I hope it's working in English. This was about the French channel, I think. So, not really a quote, rather a combined word, but quite frequently the immediate reaction, I think. So taking into account that the average duration and after the real technical problem still on stage here. I'm sorry. Can someone help us? We're hearing a translation on the monitor here. I can sing the title theme of Jeopardy, if you like, as soon as this problem will be solved. Thank you for that. Okay, please let me repeat my last sentence. The fact that endometriosis is diagnosed on average after 7 years. There's the impression that medical science are sufficiently aware of this problem. That would be a first question to all panel members. What was the first awareness-raising element about endometriosis? Was it a topic that was approached in theory and you're doing a studies, or was it rather a really diagnosed case and a person in your presence pushing you to deepen your knowledge about the topic? Maybe because you are just next to me, I'd like to start with you. Well, the initial phase is a bit difficult, but it should be okay. And the mic is working. Well, actually, during the psychology studies, this topic had not been approached at all. In my sexology course, rather than was the case where we could talk about certain difficulties in the sexual life of a person suffering from endometriosis, but it was just a preliminary approach, not really into depth, and was a quick approach with just the broad ideas and nothing in depth. And as many of my colleagues as well, at the time, about 20 years ago, a patient came into a consultation, and she did not come and see me for that person. She had just a difficult life phase. She was separated from her husband, had adopted 2 children. At a certain moment of time, she could share with me this particularly difficult part of her life, and what touched me the most, I remember, was a feeling of being completely alone with it, and asking professionals and experts about it, or her husband as well, or friends and family around her. A lot of suffering going on, and she said that she kept that for herself, and at a certain moment in time, she ended up saying that maybe she was just exaggerating, making too much fuss about it, and she should learn to calm down and minimize what she was feeling about that. And here you realize the physical suffering, but also psychological distress in sexual relationships as well. That's why we'd like to come back to this in a quarter of an hour. Mr. Stieber, what was the first confrontation for you? Well, I was at the same university as Professor Skifle, and both of us were quite early on confronted to endometriosis, your European Reference Center. It was a major center of interest in the research work being done there, and both of us, we were research students with Professor Boudin at the time, and concerning endometriosis, we were really in the middle of the topic, and this accompanied us during our whole professional career. Thank you. Mrs. Hilt, can you... Are you hearing me? Yeah, okay, excellent. Could you explain when you got confronted with this term for the first time? Was it during your training already? Because you were trained as a nurse, or you had several educational trainings. So when did you, for the first time, encounter this concept? Well, endometriosis came up first in my training as a nurse at the Grün. Patients came to Perseverance for endometriosis and sanitation procedures. So for quite a while, I was not confronted with it anymore. But when I started my training as a naturopath, I specialized in gynecology and the kind of more about reproductive medicine and accompanying measures in naturopathy and Chinese medicine. And so I got more and more patients wanting to become pregnant and talked about endometriosis or menstruation pain, and with such a diagnosis they came into my office, and that's when I deepened my knowledge base about it. And this must be some kind of a never-ending process as well. It will never come to an end, always learning more. So, Mr. Skifle, what was your first encounter? But you told your story a little bit about that as well. Maybe an anecdote or a specific confrontation with endometriosis early on in your studies. Well, as said, I was born in endometriosis in a way as a professional, but I can confirm what really changed in the perception and still has to change in the perception. It is not a unique presentation. There's no one-size-fits-all solution for all cases and patients, and that's what's bringing up a lot of questions as well in the research area and in the medical field in general. There we could observe that there was a connection between endometriosis and the nerve system, and launching new path of research and include several therapeutic approaches to be really able to help these patients. As indicated already, patients are not really expressing or do not dare to express what they're feeling about. And early on in my studies, I thought that surgery would be able to solve it all. But very quickly we had to see that the psychologists were needed in the teams as well. And physiotherapists as well. Physiotherapists, some of them telling me it will never work. But I say, you have to try. You have to try and help. You have to propose solutions. Patients will work with dietitians, others with physiotherapists, others with psychologists or sexologists, because they're suffering and not expressing it. They don't explain it to their family circle, to no one. And suffering, you are aware of it, but the suffering of a woman not being able to get pregnant, and no doctor really listening, the husband and the family not listening to her, this is huge distress, great suffering, which can lead to divorce, separation, and increased solitude as well. And we really feel that. Unfortunately, as a doctor, I cannot always deliver an answer. I'm not an expert in all these areas. And again, there's a multidisciplinary approach that has to be chosen. We'll get back to that as well. Thank you for your input. Let's continue with my next quarter question. I think it's a little bit tough. I thank the person who gave me this quote at the meeting we had beforehand. It was really a tough life, but no clear diagnosis. As an example, one of the questions that were put by a gynecologist, but why do you want to be ill? She said, how would you qualify such a question? And is this an indicator of quality in the relationship between patients and the medical profession? Maybe I might start with you this time. Professor Skifle, what's your opinion? Well, my recommendation, if you're asked this question one day, would be to say goodbye to the person and never get back to her ever. And most of all, it's like in friendships or in family relationships, you have to find someone else. One day there will be someone showing up, being able to help you, to recommend things to you, and help you really. But you have to be humble from our side as well. We have no miracle solutions here, but we have to be present. We have to listen, and a good knowledge base is a very important step in this as well. Even if I come to a conclusion, if I'm seeing a patient by saying, well, I think I cannot help you, I have no surgical solution to you, what I might recommend would be this and that, and the patients tell me afterwards, thank you for listening. And if they tell me that, that's because no one did before. Thank you, Mrs. Hild. So you heard the quote. What does such a quote say about the relationship between the patients and the medical profession? What do you feel when you hear something like this? I feel a huge distance. I think that there should be a relationship of trust between patients and doctors, or patients and therapists. That should be the first level. I see quite often patients coming to see me with such a diagnosis, and patients being told, I can't do anything for you, who come and see me, then and try to find another way. Today I had a call from a patient coming back after the fourth time trying at the clinic. She could still not get pregnant, and she was in distress, and she wanted to see me and talk to me and have someone who's not questioning, oh, she's been done, do I have really this distress, is there so much suffering, is it real? Seeing someone who will simply listen to you and have some understanding for your feelings and your position. I think that's really important to feel that you're not alone, all these women. Well, the pandemic is behind us. Almost. It's almost a lie, actually, to say that it's over. But we know that the medical field has been put under a lot of pressure due to that, and there was not a lot of gratification as well. So from your side, you have your experience as a nurse in a broader context, I reckon, and now you have your own office. Do you have the impression that you have more time for persons who didn't have such opportunities in their daily life before? Yes, absolutely. I've been working for more than 12 years now in my own. I've been self-employed for 15 years, but I'm in a palliative care station with naturopathic interventions once a week, and I see a major difference in the time nurses have for the patients and the time I have, and the clinical daily business interaction with patients, so feel really accompanied. It's not really covered at all. So as a nurse, you cannot really make enough time available for these patients to be there for them and to listen. Thank you for sharing your experience. Dr. Stiber, you also have a clinical experience. What would you say seeing such a quote? Well, I think the first matter here is a relationship of trust between doctors and patients, and important quality is to have an empathy for the patients, to believe what they're saying, to be interested in her, and to bring back what we have heard in training. So ask questions to the patients and listen to them. This is a little bit a point of criticism for the medical field. There's more and more technology, but the ability to listen and to get involved in a case, that should be weighted at a much higher level. And we have to define medicine another way. Quite a long time ago, there was a curative approach. We have to cure people, but in chronic disease cases, we have to accompany them, we have to care for them in all circumstances, and this is a completely different approach. Thank you. In my personal view and personal life, forgiveness is important as well. Mrs. Antoine, do you think there's a possibility that apologizing from the doctors who have said something like this, an apology might help, you think, or will this never happen? Well, first of all, personally, I would like to say that such a sentence is an act of violence, actually. I think this is unacceptable in any way to say something like that to a person because it's generating a lot of guilt in the person. It's her fault, she's not doing it the right way. So I'm absolutely in agreement with everything that's been said about this by the other panel members. But I was wondering as well whether the medical professions in general, confronted with a chronic disease, have sometimes difficulties to find an adequate approach. They feel unable to really deliver treatment that is adequate for the person. Maybe this leads to an approach where you want to bring the patient herself to responsibility, to generate some guilt, maybe unconsciously. I'm not saying that they're doing so willingly in their own helplessness, but there's a necessity for all representatives of the medical profession, not only doctors, to be able to question themselves, to deepen their approach. What is really touching me here? Persons I can't heal or cure, and this is sometimes completely missing. But this here is an act of violence, as we can observe quite often in situations in the medical world. Thank you. So a lot of persons concerned were telling us that quite regularly their surrounding persons were indicating that the pain was only in their imagination, and the final diagnosis was really confirming a physical origin of their pain. So it was a relief for them. The link between physical and psychological parts, I think maybe should favor a holistic approach here. Mrs. Antoine, may I ask you to start this round? Yes, you're absolutely right. I think everybody said so as well. We need a really multidisciplinary approach right from the start, if possible, because quite too often long periods of time pass when the persons are with themselves completely alone, and there's a complete absence of diagnosis. And it's important as well not to create a sort of split in the person, supremacy of the body, supremacy of the mental, the mind, but to have a reunification of the person as a whole, and it's in his, in this case, her globality, and to really support this coming together in choosing the right approach. And the approach has always to be really centered on the patient. It should not be a really tough path. Have to find the best experts and professionals. No obstacle course to get there, and such a holistic approach, the care and management approach that will be chosen will be completely positive, constructive, and it's not only in people's heads, and it's a real relief for the persons when you see all the repercussions that endometriosis might have, as indicated already. It's quite clear that is multidimensional, multifaceted, and we have to take this as a basis. Yes, but the negative connotation of psychological problems, has it changed a little bit in the last years?
Oui et non.
Yes and no. I think that going to a sexologist, a psychologist, or the like is something that has become more normal nowadays. However, on the other hand, it is a little bit of an escape. It's very easy for certain professionals to say, well, it's all in your head, and it makes it difficult for the patient to get out of this terrible vicious circle of denial. Yes, I think that we can all agree that a multidisciplinary approach to deal with this pathology is fundamental. And family planning is also important. And involving the family in dealing with it is fundamental. I think, however, on the other hand, it is very difficult for the multidisciplinary approach to be implemented because in hospitals there is maybe half a psychologist's post pretty much that can follow people up when they're at the hospital, but access to care is not always very easy, and sometimes people are not necessarily interested in following up this particular pathology. On the other hand, there are very few sexologists in Luxembourg, for example, so their timetables are stretched. And once again, we hit the problem of unavailable care. So if somebody has to be followed by a psychologist, a sexologist, and others, and has to pay everything out of his or her own pocket, that is difficult. I think that the CNS needs to make some changes. At the moment, there is no financial coverage that is provided to the patients, and it is up to the hospital itself to establish a multidisciplinary approach to deal with this matter. And in terms of outpatient care, this is complicated, and I do think that this demonstrates clear lack of respect for this illness, because in this case, many patients do not receive reimbursements. Once again, it creates a gap between people who have the means and those who don't, because those who have the financial means to do so get the right care, and the other ones don't. They're sitting alone in their corners. So it creates great injustice. Thank you. Mrs. Hilt. Now, the separation between body and mind is something that is often done. Now, what do you think about it? What is your take on the separation between discussions about the mind and discussions about the body? Now, personally, I find that the vocabulary itself that we use is complex. Yes, I think that in terms of naturopathy and in Chinese medicine, we do not separate those two concepts. Now, in Chinese medicine, we talk about it in totally different terms. The diagnosis is different. It is dealt with from the angle of the blood. And for example, sometimes it can be the result of blood stasis, for example, and this can be caused by stress, by gluten, and so on. So the way the issue is dealt with is completely different. In naturopathy, we always try to find the root cause of an illness. In traditional medicine, we always look for we look for different forms of diagnosis. In Chinese medicine, we also deal with things different, for example, through massages, through acupuncture and the like. And there are other aspects that are also taken into account. For example, stress. Stress can be caused by an unhappy job situation, by relationships that are toxic. So, in my opinion, we cannot separate body and mind. It's not possible. Thank you.
Monsieur.
Thank you. Mr. Sciffier, would you like to add anything?
Le message.
Yes. First of all, we need to identify and name the illness. It is very different to expressing a symptom. The patients need recognition, and then there has to be recognition on the level of the care. Now, in terms of the experts center, so medically assisted procreation systems analyze the reasons for infertility, for example. Why wouldn't the same be done for endometriosis? Why wouldn't there be sexologists, nutritionists, psychologists, and so on, to at least be able to inform the patients on what they can try, on what they can, on what they could potentially do? That is part of care. Yes, I do realize that in the medical field we have to clearly define what an expert center is, but we need the financial means to do so. Personally, for example, I don't have access to psychologists, and in terms of the establishment of the experts center, the directors of the hospital I work for, they ask me how much the psychologist can come. And for example, the physiotherapist that does the work in my center is a student. She's doing it for free. And we lack the financial means to actually provide adequate care to these people. Thank you very much, says the moderator. Let us have a look at this expression. Here again, I am sure that many of you have heard it. Now, when I did some research for this conference, about 50 people that I asked the question to confirmed that most people around them said it is normal to feel pain while you are menstruating. So, what is your take on this so-called normalization of society about such pain? And what approach could be adopted that would help both society and the person concerned? Madame Antoine.
À nouveau, je trouve que ça rejoint déjà des choses.
Yes, this comes back to a lot that has already been said. Once again, we're dealing with stereotypes that run wild in our society about what it is to be a woman. So, having periods, having children, the menopause, and so on. It is considered normal to feel pain, and one must not exaggerate, because otherwise the people complaining of pain will be considered neurotic. Now, you showed us we have listened to testimonies from patients, and they have more expertise than the experts themselves. And what they say really demonstrates how much they suffer when they hear, well, it's normal to feel pain. And what happens? The patients stop expressing their pain. It's very dangerous indeed. It's dangerous for this person's life, for this person's medical care. And I would really like to insist that the people concerned should continue expressing their pain and their suffering. It is not normal to suffer. As Professor Skifley has said, if somebody says that your pain is irrelevant, then look for someone else. Go to discussion groups, belong to associations. Move away from those people, but do not accept that reality, and find people who will listen to you. Thank you. Mrs. Hilt. How many people have gone to you and said that people have told them that pain is normal? And could you please say who says that? Are they people from the patient's in close environment, or from their partners? So, who normalizes it? When I ask a patient when I ask my patients about their menstruating pain, their period pains, they often tell me, "Well, I get normal pains," and then I ask them to describe it. So usually it's the patients themselves, the women themselves, who say that their pain is normal. There is also a big problem on the level of taboos. Periods are taboos. It is, like, for example, thanks to tampons, people can continue going to the pool, they can continue going to work, and so on. In the past, women had, when they had their period, they were allowed to express a certain level of neurosis, for example. They had days off. I think that we need to be realistic. It is normal to have one's periods. It is also normal to sometimes want to move away from people when we're feeling that way, and it should be considered okay. Maybe it should simply be accepted that we're not in a good mood. And then, if that were accepted, then partners may look after the children when the woman has her pains, and so on. I think that women should be more open about their own bodies, and that we should not always have to stand as men. That women should not feel obliged to have their period, look after their kids in a brilliant fashion, and look fantastic. That's not fair.
Les gynécologues, je me pose un peu la question si vous...
No. As a gynecologist, do you ask people about the scale of pain during their periods? Do you ask them this? So what is your experience in terms of the responses that you receive? The word normal is already problematic, but do your patients consider their pains to be normal or not? During the consultation, many women pain about their pain when they really feel it. When they have the opportunity to talk about it, they can. And I think that in any normal consultation, we should ask patients whether they feel pain or not. And the pain is subjective as well. Some people's pain thresholds are higher than others. We need to treat people's subjective pain too. In our society, throughout evolution, society has gotten used to and adapted to the reality of female pain. Now, women are allowed epidurals during pregnancy, but in the past, sometimes childbirth was a terrible experience, and they had 3, 4, 5 children. And so for many years, a society just got used to the fact that women are very used to pain. Until 2005, an epidural was not reimbursed by the Luxembourgish medical system. It really demonstrates that society is very subjective when it comes to pain for women. And the discussion about having free days or days off when women have their periods is something that definitely should be put on the table, because it is part of being the reality of being a woman.
Pour trouver des catégories pour
Professor, how do you categorize pain in terms of levels? Is it difficult even in research to find the appropriate words to describe pain?
Mais les experts sont les
Well, the experts are the anaesthetists. They are the ones who are used to those kinds of scales. And the most common one is to ask people to say what their pain is on a scale from 1 to 10, and that is very subjective. Now, as far as the normalization of pain is concerned, and the interpretation of pain needs to be taken into account. If the pain is disassociated from periods, that is one thing. Now, before the contraceptive pill was invented, very few women had their periods regularly. Why? Because they were often pregnant, or they were breastfeeding, and so on. And now, with the contraceptive pill, the periods that people are experiencing when they're on the pill are actually totally artificial. I think the association and the meaning that we give periods is important. The meaning that we give fertility or infertility. I had a patient who did not have her periods, and she was trying to conceive, but was unable to. And she phoned me 4 weeks later after treatment, and I treated her, and so 4 weeks later she phoned me and she said, I've got my period, and she was crying of joy. She was in the supermarket and she couldn't find the sanitary towels, but she was delighted. For 20 years she hadn't had her periods because her ovaries weren't working. The thing is, pain is normal? No, it's not. It's an interpretation of pain. We need to be able to express discomfort. And if this discomfort has an impact on our life, then that's important. If it has an impact on the quality of our life, on the quality of our work, on the quality of our relationships, on our joys, on our physical activities, and so on, then that pain has to be expressed. So basically, if pain has an impact on the quality of life, then you have to be open to discussing it. And those are the reference points that we need to give people.
c'est important de parler encore de genre.
Yes, I think that we need to speak about gender as well. Once again, we have a rather interesting quote here. If it were a male disease, ... If it were a male disease, for example, a miracle drug would have already been invented. So gender is a very important aspect of these discussions. And we can see the various experts here. Now, would you like to discuss, for example, the different roles of each person who is here on the panel? So, for example, on this panel, we have the soft skills and the hard skills that are distributed across gender. Does this bother you? Do you find it important? Do you not find it important?
Okay, je peux aussi poser encore la question.
I'm going to ask this question to Mrs. Hilt as well. Concerning your interpretation, please. No, I didn't follow in the... I'm going to repeat the question in German then. So we got some feedback based on the gender distribution in our panel, because the doctors are male and soft skills or alternative treatments would have female representatives. I just wanted to put that question to our panel members. Do you have any comments? Or is it not relevant? You are entitled not to answer as well. There was just a feedback of... Now I have to say that in the Luxembourgish gynecology scene, women rule. So there could have been a female colleague. So there's lots of them. So from my point of view, it's an artificial topic, okay? But quite often, as a matter of fact, men are more in an operational approach, and gynecology, women involved are rather in the area of obstetrics. So men maybe more on an operational level than women. So, Mrs. Hilt, you wanted to... Not to comment? No. Now I understood the question, so I'd like to give you a comment. I have the impression as well that it's the male domain, the level of doctors, so medical profession, and women rather, in the midwifery. I don't know any male representatives in the Chinese, yin, the softer, calmer, more female type of work, or rather soft skills, and younger, the stronger, more dynamic jobs are rather attributed to men, but in the area of classical medicine, I think that doesn't really deliver any big differences. For those interested in the topic amongst our audience, so we will transfer the question and answer session to the entrance hall for our cocktails afterwards, and you can ask questions to our panel members as well. So I have to switch languages again, sorry, says the moderator. But we wanted to talk about denominations, about the terms male and female on the flyer. The flyer for this event, preparing the event, states that 1 in 10 women would be affected by the average endometriosis. But the wording is not totally correct, because trans men who still have their uterus can be affected, or transsexual men as well. What I would be interested in with your different levels of experience, have you experienced, for instance, with transgender persons in your professional daily life? And I would like to know as well whether the medical profession is aware of this topic. Mrs. Antoine, are you ready? This is a complex question, actually. For me, well, I think that all health professionals at all levels, even persons welcoming patients in the secretariat function, they all should be aware of more vulnerable persons in a weakened position, because they might receive more sexist comments or remarks or negative innuendos. So it's a more difficult position. So an awareness raising has to be entered concerning all vulnerable persons, LGBTQI, are involved as well, but also disabled persons, the elderly, persons with a migratory context, homeless people. So there's lots and lots of different weakened groups in society, and all the socioeconomic factors are having an influence as well. So leading to a situation that some people will not have an opportunity to have access to certain types of aid or care. And a political awareness raising has to be reached as well, and this will involve also awareness raising measures, training measures, and as indicated, we have more fragile groups in society, but persons accumulating discriminatory aspects. You can have a person being a woman of color, a lesbian, and additionally obese. So you can have a whole series of discriminatory factors that might come together, leading to a decision where a person is even more stigmatized. And we can see that a lot of work has still to be done here. Mr. Stibert? Yes. Followed the training in Germany in the service where we had a few transgender persons, and the topic was lost in Luxembourg in the last 20 years, at least for me. And so I was wondering where these persons were cared for. Did they dare to present themselves for someone's not possible or not easy to go to gynecology. I had two cases where surgery was asked for, and even within our own medical practice, it was not obvious to accompany these persons in an adequate way. They're in a more fragile role in society, under more surveillance, more monitoring, maybe not feeling well, secretaries not knowing how to call or to address them. So at the end of the day, it was okay. We had a good approach, but there's a little bit of a blocking situation initially, how to welcome them and to offer them an entrance door in an adequate way, because it is a part of the population which is a little bit in a discomfort situation, and they don't have the same access to care measures. Mrs. Hild? Can you talk about your own experience, for instance, with trans persons from your daily activity, and how has your awareness been raised? Was there an auto-awareness raising, or was it part of your training? Well, in my cabinet, I haven't had any cases at all. In my practice, I live in a small village, and in our village we have one girl who wants to be addressed as a boy, and it's quite interesting to see how children handle the situation. Typical girl beforehand, little dresses, and now shaved hair, dark clothes, and wants to be addressed with another name in a small village. It's quite interesting to see what is going on there, what discussions are taking place, and the gossip generated by that. I think there's going to be challenges coming up in our society in general, but in my practice, I didn't have any contact yet. Yeah, but it's good to see when children are preparing the word for the health professionals. Yes, but it's important to explain that to children as well, to teach them tolerance as parents, and not just pointing your finger and participating in gossip, what quite often happens. So teach children that each and every can be as he or she wants to be. Yes, absolutely. Thank you for that. Mr. Skifle, concerning research, gender health gap is a term being used. Can you tell us more about that? I didn't understand. Gender health gap. Can you give us a comment? Well, right now, I couldn't tell you much about it, and everything unknown scares you. And in a certain way, it's about knowledge and understanding and exchange. It's about teaching education, responsibility that you have at a university level as well, and in our society in general. I see here an analogy at the initial phase of AIDS and what happened there and all the errors that were made at the time and are still being made here and there. In a surgery room, we had protective glasses and it was put in huge letters AIDS on, and we're walking around in the operating room, and everybody could see it, and the secretary answering a telephone in front of a waiting queue for a colleague specialized in AIDS, and she said, Professor Yombi only sees AIDS patients, and a young person says, I have an appointment with Professor Yombi, so in front of everyone. So this is a continuous stigmatization. You have to use the right terms, welcome people in a accompaniment in an adequate way, and it's the same for race and ethnic origin. It's not only about AIDS, it's only a lack of knowledge. Everything foreign scares you, and we have to open our minds, and this has been taught as well, and this is progress. Because as just said here by my panel members, these persons are expressing distress and pain. They have to be recognized, helped, accompanied, and recognized as well. It is a genuine field. This has not to be corrected. You don't have to treat this aspect as an interpretation you live. It can broaden the debate about this, of course, but this is important for all patients in the broadest sense. All persons need to be recognized as a full-fledged person in their own right, and the future will tell us how this will evolve in all the areas of apprehension we had in our society and in humanity. This is a matter of progress. We could discuss for hours about the access to procreation for these persons. At least in Belgium, we have progressive legislation that have been adopted. Initially, this led to problems, but everywhere in the world, people are saying that Belgium has a progressive legislation. Not in all areas, I have to admit immediately, but this makes us proud, actually, yeah. So at the end, the most important topic in my view, we need political solutions. You have mentioned already the national strategy in France. Maybe we could formulate some recommendations for politicians in Luxembourg, if they should have an intention to launch such a strategy or approach for Luxembourg. Mr. Skifle, do you have recommendations concerning possible aspects that should not be forgotten about if Luxembourg should launch such an initiative?
Ces réunions sont très importantes.
These meetings are very important. It's not the first one that I go to. I know that we've had to deal with COVID recently. But from a medical viewpoint, we are under pressure, and it is actually a positive thing. The expert center is important, but I will ask you a question, just food for thought. What do you consider an expert surgeon to be? How many times does a surgeon have to perform surgery to be considered an expert? This is just a matter of perception. If you go and ask a carpenter to do some work on your house, how do you assess his experience or her experience? In Belgium, we began to centralize certain pathologies, for example, cancer, so the esophagus cancer and so on. Now, in order to recognize an expert as such, 20 operations have to have taken place. That is what we consider to be an expert center. Now, is that many? operations? Is that not many operations? Is that so? It's taken years to reach this stage. Now there was a political pressure, medical pressure. For example, some doctors might say, "Why is this person considered an expert and not mine?" etc. So it is important as well. People have to be humble. Doctors have to be humble, and they have to recognize that they cannot do everything. For example, if I am fighting for the expert center for endometriosis in Belgium, it is because I know I cannot do everything alone. There is also a hierarchy in terms of the care for the people suffering for the pathologies. Laws, funding have to be available, and the medical profession itself has to structure itself and establish a register containing the number of patients, the successes, the failures, all the statistics, and so on. Belgium does not have that yet. Of course, for example, if I am asked to perform 20 operations to be considered an expert, then of course I'm going to perform 20 operations. That's the way it works. And if an age is determined, then so basically what I'm saying is there are always biases. There are always biases. Not everything is perfect, but it is a step forward. And the patients, the medical profession, the political level have a role to play. The endometriosis must be considered a priority, and people must join hands in order to present it as such. No, the system's not perfect, but I stayed in Belgium because I do feel that Belgium does not lack means like some other countries, and it also does not have a division of specializations such as in the Scandinavian countries or the UK. In vitro fertilization is reimbursed in Belgium and France. It is possible to do that. That's not the case in other countries, but there has to be a political goodwill behind these movements, and access to reproduction, for example, has to be access to everybody, couples and singles.
Also es gab eine parlamentarische Anfrage bei uns in der Abgeordneten.
In the chamber of, in the parliament, our Minister of Health stated that a strategy should be established for endometriosis. Now, if you could choose from whom you could take advice from, who would you choose? Would you recommend that people consult naturopaths too? Yes. I think that would be very good. I have done some training on assisted reproduction and reproduction in general. I went to a school in Bonn to do this. And acupuncture did help, and I do think that acupuncture, for example, could also help people suffering from endometriosis too. It could be done as an accompanying and supporting form of therapy. The experience from my practice really demonstrates that the combination of traditional medicine or conventional medicine and naturopathy works very well. The problem is that people suffering from endometriosis and who go to a
fertility clinic, yet they also go to a doctor to treat their endometriosis. The fact is that these two medical fields can communicate very little with each other. So, for example, in Germany, sometimes the treatments are reimbursed and sometimes not. And the thing is, there is no difference made between people who simply want assisted reproduction because they can't, or they've been trying for a while and it hasn't worked, or whether the sufferer truly suffers from endometriosis. This should be done. You're allowed an X number of cycles. And the fact is that infertility affects people with endometriosis quite a lot. Thank you very much.
Des personnes est longue, je dirais, qu'on doit donner au ministère.
Okay, so the list that we need to provide the ministry would be rather long in terms of the important professions that could get involved. Yes, I think that politicians should respect specializations. There is a certain level of centralization that has been performed. There is no center in Luxembourg for endometriosis, but various hospitals are working on it, some more than others. There is a structure, there is collaboration in place between different hospitals. And it does work rather well in terms of collaboration. However, there is no multidisciplinary approach. So on the medical level it works, but not on the carers level. So we do communicate on the level of doctors, but for example, psychologists, sexologists, physiotherapists, and so on, do not communicate like we do, and that would require a lot of work. The thing is, politicians sometimes want a centre for excellence, but they provide the concept, they don't provide the means. So, for example, with the 80 beds, we're allowed 1/4 of a social worker, 1/4 of a psychologist for the entire process, and it is the CNS that decides on this. And the only people who are entitled to such care, so for example, psychologists and the like, are people who are hospitalized. So anybody who is in outpatient care cannot have access. So unfortunately as well, these professions such as the psychologists and so on, they have a lot of work and there are waiting lists, and we have waited for 10 years. And currently, we're still negotiating. Zero. We have 0 psychologists, zero sexologists. And for physiotherapists, people are allowed 8 sessions. So really what needs to happen is that the multidisciplinary approach needs to become a reality. It can't simply remain abstract. So a multidisciplinary approach is beginning to be adopted with breast cancer, for example, but we're dealing with limited means. There's also quality checks that need to be performed, and the means, again, that we are provided with, 0 practically. So basically, the population needs to put pressure on the politicians, and it's not sufficient for a Ministry of Health to simply utter some beautiful sentences Really, what needs to be done is the plans that have already been established need to be implemented, because the problem is people lose steam, and we need to do some more work so that we can structure patient care better. Do you have something to add, or has everything been said?
Tout a été dit. Non, je voulais juste ajouter, je suis tout à fait docteur.
I just wanted to say that I totally agree with you, Doctor. Nowadays, we see that, for example, in the public, people are affected by the matter of endometriosis. And we need to promote such awareness-raising situations. It's not all about theory and great concepts. No, I think that we need to focus always on the person, whether it be the patient, and this is totally in a non-binary approach, because everybody is going to require a differentiated treatment. There is no miracle treatment here. What works for one patient will not necessarily work for another. And we truly need to take into account the patient's difficulties, experiences, and take into account all the different facets of endometriosis. Because endometriosis has public health repercussions, and that needs to be expressed. Thank you very much. I would like to thank those on the panel. I would also like to thank the public, the organisers, the technicians, the interpreters. And trust me, it's even hotter in the interpreters' booths than in the room. And I would also like to thank those who are providing services outside. And I think that we can have an even more in-depth conversation outside. Let's carry on this conversation. The fight continues. And I am really pleased to see that we will be fighting alongside each other. Thank you very much.
Il y a encore un petit cadeau. Ah oui, et ce qui intéresse toujours les Luxembourgeois.
So, yes, and the Luxembourgers are always interested in what I am now going to propose, a glass of wine.